Hi, my name is Ty Gluckman. I'm Medical Director of the Center for Cardiovascular Analytics, Research and Data Science at the Providence Heart Institute in Portland, Oregon. It's my pleasure to bring you another installment of quick tips for fast thinking, specifically focused today on COVID-19's impact on non-communicable diseases, the enormous toll it has taken. I have no disclosures. And I think as nearly everyone on the planet has realized that SARS-CoV-2 virus has dramatically changed the world and healthcare as we know it. I'm going to take the opportunity to walk you back over the last 6 months because I think it's really important to understand much of the data is put into context based on this. This is data that comes from the Johns Hopkins Coronavirus Resource Center and plots out a number of the different countries and trajectories of confirmed new cases that took place extending back to the earliest portions of March of this year. And as you can see, the United States is listed in orange, and beginning on or around the mid portions of March, we saw a significant uptick in cases, as is illustrated by this circle here. This obviously set into motion a number of steps that hospitals took to avoid being overwhelmed. It's really interesting when you think about this to look at many of the concerns that revolved around our ability to potentially exceed hospital capacity. And this is data that comes from the Harvard Global Health Institute, and it's modeling data looking at the rates at which individuals would become infected and at over what period of time, and the extent to which this could overwhelm hospital capacity, moving in the left upper corner to the right lower corner, at which point, if we saw 60% of infected individuals over 6 months, we would drastically exceed hospital capacity, but even much less pronounced rates of infection over longer time horizons really had that potential as well. Many of you have seen slides like this from the Centers for Disease Control and Prevention that highlight the fact that without protective measures, many of us would have quickly overwhelmed our hospital's capacity, whether in terms of emergency department beds, ICU beds, general medicine, mechanical ventilators. And so as is seen by the horizontal dashed line, many of us took steps to try and bring our case rates below this so as to not overwhelm our hospitals. A concept that's been talked about a lot is flattening the curve. And the hospital that I work at, many of the hospitals that you all work at, took a number of steps to try and help reduce the number of patients that were presenting to our acute care facilities. I was fortunate to be involved with this guidance document that was issued by the American College of Cardiology early on. And this was issued back on March 24th of 2020. And I'll quote just a portion of this overall, but one of the key strategies that many of our hospitals, our executives, including governors in our respective states, is the deferral of non-urgent procedures with a goal of trying to remove those individuals that may otherwise have the opportunity to delay their procedures so as to not crowd our hospitals, ICUs, and needs for mechanical ventilation. So with a primary goal of reducing the risk of infection, the spread of COVID-19, the intent of protecting our patients as well as our healthcare teams, and enhancing capacity to respond to the pandemic while preserving access to necessary cardiovascular care, many clinics and hospitals have begun deferring non-urgent cardiovascular testing and procedures. And we had issued as a guidance that it's reasonable to consider deferring any procedure that's unlikely to directly impact clinical care or outcomes over the next several months. Now, this was issued on March 24th of 2020, and little did we realize the projected length at which we'd be dealing with COVID-19 now some 6 months later. So all of this engendered for many of us unforeseen consequences. And some of you may have seen this write-up in the New York Times that was authored by Harlan Krumholtz at Yale that was titled, "Where Have All the Heart Attacks Gone?" And it was a realization on April 6th of 2020 that many of us that were on the wards were not seeing the usual cases of heart failure, acute myocardial infarction, acute strokes that we were all used to seeing in our hospitals. And so it begged the question, what unforeseen consequences in an attempt to shut hospitals down by flattening the curve so as not exceed capacity may have been unforeseen. We began to see signals or the results of this across the world. And this was an initial report that was published in the European Heart Journal looking at reduced cases of acute myocardial infarction admissions in Austria. It was a national retrospective survey on the impact of COVID-19 on acute coronary syndrome admissions to 19 hospitals in March of 2020. And you can see at the bottom along the x-axis the calendar weeks in the year 2020, weeks 10, 11, 12, and 13. And all ACS patients are illustrated in blue, STEMIs in orange, non-ST segment elevation myocardial infarction shown in gray. But you can see even as a week-over-week basis, the numbers of individuals that were being admitted with STEMIs and non-STEMIs took a downturn. We see similar data like this in Italy. This was published as well in the European Heart Journal, looking at reduced acute myocardial infarction admissions in Italy. This was a multi-center observational survey on admissions for acute myocardial infarction during a one-week period during the COVID-19 pandemic compared to that equivalent week in 2019. 2019 data is shared in blue, 2020 data is shared in gold, and as you can see, there was a nearly 50% reduction in acute myocardial infarction, a 27% reduction in STEMI, and a nearly 65% reduction in non-ST segment elevation myocardial infarction admissions. We got our first glimpse of this in the United States with this publication in the New England Journal of Medicine. It was a cross-sectional retrospective analysis of acute myocardial infarction hospitalizations between January 1st and April 14th in years 2019 and 2020 within the Kaiser Permanente health system. And as you can see here, data shown in 2020 in red and that in 2019 shown in yellow or gold, we began to see on or around the earliest portions of March a downturn in the number of acute myocardial infarctions in red as compared to the corresponding time period in 2019. Superimposed on this graph as well was the rise in COVID-19 cases that were observed in this region related to COVID-19. All of that begged for us internally as we were see reports in Europe, and we had seen the piece that was authored by Harlan Krumholtz in the New York Times, what was going on in our own health system. So I work as part of a larger health system, the Providence St. Joseph Health System, that extends all the way from Alaska down to West Texas across 6 states, begging the question, what was the impact that we were observing in the Western United States? And taking it a step further beyond just what were the case counts, what was the impact on treatment approaches, in-hospital outcomes, and were the patients that were coming to the hospital any different from those pre-pandemic in terms of acute myocardial infarction? So this was a cross-sectional retrospective analysis of acute myocardial infarction hospitalizations, 15,244 of those that involved 14,704 patients between December 30th of 2018 and May 16th of 2020, again in 6 states in the Providence St. Joseph Health System. We utilized ICD-10 codes to define the population, and we excluded patients that were admitted on an outpatient basis, which is unusual for acute myocardial infarctions. The primary outcome of our study was weekly rates of acute myocardial infarction hospitalization before and after the pandemic onset. And we additionally looked, as previously noted, at patient characteristics, treatment approaches, and in-hospital outcomes, including mortality, length of stay, and discharge disposition. We did a segmented regression analysis that was performed to assess changes in weekly case volumes, and we divided cases into essentially 3 periods. Those that predated the pandemic, the before COVID-19 period, an early COVID-19 period that was for 5 weeks, and a later COVID-19 period that extended to the duration of the study period. We looked at in-hospital mortality, and we risk adjusted it using an observed to expected ratio, as well as a covariate adjusted multivariable model. This was published in JAMA Cardiology in the early portions of August of 2020. So this is the sole figure that we have in the publication, and it gives you an understanding of the impact from the pandemic. Shown in a dark blue or a black color is a line graph representing the weekly of acute myocardial infarction overall. in a lighter gray, non-ST segment elevation myocardial infarctions, and STEMI shown in an orangish color. And you can see the temporal changes over time. The dashed line represents the best fitting line for the period pre-pandemic, the early pre-COVID period, and then the later COVID period as well. The vertical blue lines, dated as February 23rd of 2020, represents an inflection point, at which point we began to see case rates falling, and then 29th of 2020 representing the nadir, at which point we saw case rates begin to rise up again. Two other things I will point out: at the upper right portion of the graph or figure you can see here is a representation of what the AMI projected rates would have been had we not seen the pandemic. And as is really well illustrated in this figure, you can see that the slope downward beginning February 23rd of 2020 was about twice as steep as the rate of return afterwards beyond March 29th of 2020. So in short, we saw a fall that was twice as steep as the rate of return or rise. And by the end of our analysis period, the weekly case rates for acute myocardial infarction had not yet returned back to baseline. So this is a very busy table, but it's important to highlight that we looked at a number of demographic variables, as well as comorbidities that are common in this population. And in short, by and large, looking at the all AMI population, those with STEMI and those with non-STEMI, there was no appreciable difference across each of these different three time periods in terms of demographic data or in terms of comorbidities overall. Largely, people presenting to the hospital with an acute myocardial infarction post-pandemic in the early and later COVID-19 periods were very representative of those individuals in the pre-COVID-19 pandemic period. One of the interesting observations or questions that we had asked, but observations that we found was, were individuals presenting with an acute myocardial infarction treated any differently in the midst of the pandemic than they were pre-pandemic? And as you can see here, horizontally represented by the before COVID-19 period, the early COVID-19 period, and the later COVID-19 period, and respectively on the left, broken this down into those with STEMI and breaking this down into those with non-STEMI. When you look at a further subsegmenting of this population based on those that underwent coronary artery bypass graft surgery in the lightest turquoise color, those that underwent PCI in the lighter blue color, and those that underwent medical management in the darkest blue color, there was no statistically significant difference in the treatment approach across all three time periods within those with STEMI versus those with non-STEMI overall. One of the other interesting observations that we found was, what were the outcomes for these patients? And shown in the upper portions of this table is a look at unadjusted crude mortality rates, risk-adjusted rates using a multivariable model, and then an observed to expected ratio overall. And the striking finding in our study was, when you look at a risk-adjusted model, that there was a significant increase in the risk-adjusted mortality rate amongst those patients with STEMI in the later COVID-19 period. And using the OE ratio, we see that in the early period and consistent findings in the later period, there was a significant increase in the AMI mortality, driven disproportionately by those individuals looking at the OE ratio amongst those with STEMI, with a stepwise increase in the observed to expected mortality rate, moving from the before COVID-19 period to the early COVID-19 period, and subsequently to the later COVID-19 period overall. So overall, consistent with previous studies, we found a substantial decrease in acute myocardial infarction hospitalization rates in the early COVID-19 period that began on or around late February of 2020. And about 5 weeks later, beginning March 29th of 2020, we saw that hospitalization rates began to increase, albeit at a slower rate. If you look at the point from where we were pre-pandemic to the point where we saw at the nadir myocardial infarction, there was a 50% reduction in case rates on a weekly basis. Among the many factors likely associated with the rebounding cases was encouragement of patients with symptoms or signs of acute myocardial infarction to seek immediate medical attention amid the pandemic. In addition, although patient demographics and treatment approaches were fairly consistent across the periods, patients with acute myocardial infarction that were hospitalized during the COVID-19 period were 1 to 3 years younger, they had a shorter length of stay, and they were more likely to be discharged. So possible explanations for this were greater reluctance by older adults to potentially seek medical attention, hospital efforts to maintain bed availability, patient preference for early discharge, and concern about risk of contracting SARS-CoV-2 in post-acute care facilities. And again, these were speculations by us about explaining the observations that we found. In addition to this, we found notable differences in risk-adjusted mortality over the periods analyzed, with patients hospitalized during the early COVID-19 period having an observed to expected mortality ratio associated disproportionately amongst those patients with STEMI. And the ratio was even greater during the later COVID-19 period. And again, this was speculated by us, but given the time-sensitive nature of STEMI, any delay by patients, emergency medical services, the emergency department, or cardiac catheterization laboratory may have played a role. Additionally, complications from delayed reperfusion may have also occurred in some patients. So that's a rough summary of where we are in terms of acute myocardial infarction. I would say that there are indicators of ongoing problems, and this issue doesn't just relate to acute myocardial infarction. This is an analysis performed by the Centers for Disease Control, published in MMWR just a few weeks ago, looking at weekly emergency department visits from a subset of hospitals in 47 states under the National Syndromic Surveillance Program. And as you can see here, the lighter blue colored line graph represents 2019 data. These are people presenting the number of emergency department visits. And in 2020, you can see at roughly week 14 into the calendar year, you see an abrupt drop that actually begins on or around week 10. As we've moved beyond the nadir that occurred on week 17 in the calendar year, we are seeing those cases begin to come back, but they're not coming back at nearly the rate that we would expect. And so much like we've seen with acute myocardial infarction, the drop is steeper than the return, in this case, of emergency department visits. This has been reflected in hospitalization rates for all causes, not just acute myocardial infarction. This was published in JAMA just a few weeks ago, looking at analysis of electronic health record data, describing trends in overall hospitalizations during the first 16 2019 and 2020 among a previously established cohort of adults in the VA medical system between 2008 and 2018. And this is looking at all causes of admission, highlighting in 2020 in a yellow gold color compared to in 2019 or grayish color, a marked reduction and a lack of return at least through week 16 of all-cause hospitalizations, not just acute myocardial infarction. And this fundamentally highlights that for the first time in my career and in my lifetime, how communicable infectious disease has had such a dramatic impact on non-communicable diseases, in this case, all-cause admissions, the prior slide, all-cause emergency department visits, and in our data, what we've been seeing and data from the United States elsewhere and in Europe, a reduction in hospitalizations for acute myocardial infarction. This is an even scarier finding that was just published in JAMA Internal Medicine. It's an observational study evaluating the number of US deaths from any cause, as well as those from pneumonia, influenza, and or COVID-19 from March 1st of 2020 through March 30th of 2020, using public data from the National Center for Health Statistics. And to orient you, the dashed line represents the expected death rate that we would see during this time period. The solid line in black representing the number of observed deaths, and seeing the difference between that being an excess number of deaths. And then it begs the question of what were the causes of those excess deaths. As you can see in this, the blue-gray portion of this interspersed amount represent COVID-19 deaths. The orange, bright orange middle represents pneumonia and influenza deaths, but the beige or tan color that is the distance between the solid line, the dashed line, that's not inclusive of the blue-gray or bright orange, represents all other deaths. And what you can clearly highlight is, while there was a spike in COVID-19 deaths that accounts for a disproportionate portion of the delta, a not insignificant amount of deaths are unrelated to COVID-19, And it begs the question, who didn't come to the hospital because they're not coming to the emergency department, they're not being admitted, they're not coming in with an acute myocardial infarction. And scariest finding in all of this is that there are people that are dying at home, not only with acute myocardial infarction, but a number of other conditions. So the prevailing underpinning underscoring all of this is fear. And this is a screenshot that was taken from the Washington Post. And whether you're talking about the lockdown, isolation, death tolls, protests, events being canceled, quarantining, these are all of the things that are instilling fear in all of the patients that we take care of. And this is what has unfortunately engendered for them a fear also that maybe they should not be going to the hospital to seek medical attention. This is an interesting screenshot taken off of the NPR, the National Public Radio website. And this is actually not what you may be thinking. This was actually a store in Philadelphia highlighting to customers to say, please protect yourselves. Don't come out if you don't need to our store. But rather you could see where this mixed messaging could be perceived by consumers, customers, also as a patient, save yourself by staying home. And we have had to get beyond the narrative where, in fact, hospitals are a safe place for you to seek medical attention, even though our governors, even though our professional societies, even though our clinicians said stay home in the case of non-urgent procedures. If you need acute care, if you need medical attention, please come to hospitals. They are safe places for you to receive acute medical attention related to COVID-19 or unrelated to COVID-19. So the American College of Cardiology and those involved with CardioSmart issued this infographic many months ago, but I think it highlights nicely the fact that if you have an acute condition, if you think you're having a heart attack, if you think you are having a stroke, please call EMS, please call 911 and seek medical attention. And we have our work cut out for us as care providers, as health care deliverers, to provide reassurance to our patients and their loved ones that seeking medical attention in the emergency department, in the hospitals, is a safe place and of key importance for them overall. Get beyond this without obviously recognizing the fact that an infectious communicable disease has had a dramatic impact on acute medical conditions, as I've highlighted over the last several minutes, but it's also having an unprecedented disruption to chronic care. And this is a survey of service delivery for non-communicable diseases between May 1st of 2020 and May 25th of 2020 for 194 ministries of health worldwide conducted by the World Health Organization. And what you can see here in orange represents a partial disruption, and in red, a complete disruption: rehab services, hypertension management, diabetes care, asthma services, urgent dental visits, cancer treatment have all been significantly disrupted for countries worldwide. And I think we haven't even begun to see the impact of what it means from a loss of cancer screening, optimal hypertension management, optimal diabetes management, what this will mean long term. So in my opinion, and many others, it's a time for consistent and unambiguous messaging. This comes from a campaign, a national campaign called Stop Medical Distancing, that our health system, a number of other professional societies, and other organizations have begun to endorse. But I think it's about communicating broadly to our patients, to their family members, to their loved ones. It's time to start talking to your doctor again. And whether it is about chronic conditions and whether it is about acute conditions, and I would argue doctors should be replaced by care provider. This could be a physician, nurse practitioner, clinical pharmacist, physician assistant. Doesn't make a difference. It's important to socially distance, so do avoid crowds, but don't avoid your checkups and don't avoid seeking medical attention in both acute and chronic scenarios. So in takeaways, the COVID-19 pandemic has had and continues to have a significant impact on all aspects of health delivery. In an effort to flatten the curve, a number of unintended consequences, and again, I do want to reinforce unintended consequences, have been realized, including marked reduction in emergency department visits, hospitalizations, and this has impacted a range of acute conditions. My own health system has demonstrated an initial significant reduction in hospitalization for acute myocardial infarction, with a higher mortality rate in the hospital that's been observed among patients with STEMI in spite of a rebound in hospitalizations, and an appreciable hospitalization rates and an increase in the observed to expected mortality ratio that's been seen broadly for a number of acute conditions with data that I didn't share yet today. Tremendous disruption has also been noted in the ambulatory setting with substantial impacts for a wide range of non-communicable diseases. And as I stated earlier, the impact of this disruption may not be realized for years, given the long time horizon for many of our preventative efforts. And I think the biggest key takeaway more than anything else is now is the time for consistent and unambiguous messaging to our patients. We really cannot afford the alternative. With that, thank you for the opportunity to be a part of this initiative. I wish you all a great day, and please stay safe. Thank you.